Thank you so much, sir. So quickly jumping into my topic today, after we heard a lot about ANA, I'll take a quick break, talk about APLA, and then again we have to come back to ANA towards the end. So the overview about my talk today would compress of the following. Around 1 to 5% of couples do experience recurrent pregnancy loss, and it has significantly increased over the past few years. After most of the patients are referred to us after they are completely, thoroughly evaluated for endocrinological, for cytogenetical analysis, anatomical abnormalities. So 50% of these idiopathic cases predominantly do have immunological factors. Now, recurrent pregnancy loss as definition per se, none of my elite societies concur to one. RCOG says 3 or more, ACOG and HRA says 2 or more, and ASRM says 2 or more. But overall, we do start evaluating the patient when there is 2 or more pregnancy losses. So evaluation of the pregnancy losses becomes very important at the period of gestation where she lost the baby. Was there any underlying cardiac activity? Was it cytogenetical analysis if it was performed on the product of conception? So this is extremely important for us. If it was a clinical pregnancy, then at what age did we lose the baby? Was it like somewhere with no fetal pole, it was just a gestation sac, or was it an embryonic loss somewhere between 5 to 10 weeks, early fetal losses which is less than 12 weeks, and late losses which is more than 12 weeks. So first trimester, predominantly less than 12 weeks losses contribute to the majority of recurrent pregnancy loss, up to 80%, which is mainly because of genetical abnormalities, aneuploidy as well as APLA. Mid-trimester losses, on the other hand, are predominantly the anatomical, which tops the list, also APLA, and the congenital defects. The late trimester would mainly be defects, fetal defects as well as APLA. Now, overall, the immunological causes for recurrent pregnancy loss contributes to close to 20 to 50%. The dysregulation in the immune system is what leads to implantation failure or miscarriage, which has its impact mainly on the placentation, the early trophoblastic invasion, as well as the micro-occlusion that it creates in the placental bed. So the commonly performed autoantibodies would be the antiphospholipid antibodies, the thyroid antibodies, and anti-nuclear antibodies. APLA. The very well-known cause in the first trimester, like I said, 80% of the causes of the first trimester losses are attributed to thrombophilias. When we talk about the acquired thrombophilia, it could either be a primary APLA or a secondary in association with SLE. Yes, we do have the hereditary component as well. But since the topic is confined to autoantibodies, the common 3 antibodies which are performed is the anticardiolipin antibodies, IgG, IgM, lupus anticoagulant, as well as beta-2 glycoprotein. But these days, especially patients who come from abroad, mainly the US belt, I do see that a lot of them have been even worked up for the anti-phosphatidyl ethanolamine as well as serine, anti-phosphatidyl serine antibodies. So these are the group of phospholipid which is not considered in the standard diagnostic criteria, but I have been seeing some of them mainly from the US belt when we do an online consultation. So, like we all know, APLA is somewhere where there is a higher prothrombotic stake, and there is going to be occlusion in the vessel leading to early miscarriages. The history goes way back to 1975, where it was first reported. The lupus was the first anticoagulant, which was lupus anticoagulant was the first to be reported to be associated with recurrent pregnancy loss, followed by Graham Huygens in 1984, who reported the anticardiolipin antibody. So here, the recurrent pregnancy loss in the first trimester is considered the hallmark for phospholipid syndrome. The second and the third trimester is mainly because of the placental dysfunction. They may present with severe preeclampsia, HELP syndrome, need of early delivery because of growth restriction or leukohydramnios. Now the clinical criteria was way back in 1999, the Sphoros criteria, this is always a very important question for us. The high risk were the ones who had lupus anticoagulant positivity, a triple positivity where all 3 antibodies are positive, or there is isolated persistently positive anticardiolipin in the medium to high titer, but the low risk is mainly the isolated ones or signal antibodies. Over a period of time, it was modified in the year 2006, which became the Sydney's criteria for antiphospholipids. it had to have a vascular thrombosis or a pregnancy morbidity with laboratory criteria. So vascular thrombotic episodes, one or more of the clinical episodes of arterial or venous or small vessel occlusions, or a thrombosis must be confirmed by appropriate imaging technology or histopathology, and thrombosis should be present without significant evidence of inflammation in the vessels. As far as the pregnancy is concerned, one or more unexplained death of a morphologically normal fetus, one or more preterm birth of a morphologically normal fetus before the 34-week period of gestation, 3 or more unexplained continuous or consecutive spontaneous abortion before the 10th week period of gestation. The laboratory criteria of, like we have already discussed, which has to be done 12 weeks apart. So this was the modified 2006 criteria. But the American College of Rheumatology, as well as the European Alliance of the Association of Rheumatology, in the year 2023 incorporated a new method of for APLA. These criteria allow the additional criteria which is scored, the scoring range somewhere between 1 to 7 points, and when they had 3 points each in clinical and 3 in laboratory, it was classified as APS. And this had higher sensitivity and specificity towards diagnosis of APLA. In the year 2013, in Brazil, the phospholipid syndrome associated with the obstetric phospholipid syndrome gave a strict guidelines for inclusion, which was early pregnancy losses, early fetal death, stillbirth, growth restriction, or prematurity. Now, obstetric APLA has its impact on the way it is going to cause preeclampsia or IUGR or thrombotic episodes in the placental bed is mainly because of the anaxin 5 anticoagulant, with the shield of which is disrupted, increase in the thromboblastic cell apoptosis, decrease in the trophoblastic cell differentiation, decrease in the trophoblastic invasion. Also because of the activation of the complements and increase in the neutrophil infiltration, and also the local TNF. We usually do a placental histopathology, which ma'am reports, and we have a lot of inflammation in the placental bed with thrombus, which concludes the pathological events which is listed here. Now, over a period of time, we did, like I mentioned, in 2023, we did classify them as an obstetric APLA. We had obstetric morbidity APS, as well as non-criteria of obstetric APLA cases. So when obstetric APLA cases, like we just discussed, 3 or more consecutive miscarriages before 10 weeks, at least 1 fetal loss at around 10 weeks plus post-cardiac activity, at least 1 premature birth before 34 weeks due to either preeclampsia, placental insufficiency leading to oligohydramnios or IUGR. Laboratory criteria, 2 LA, 2 cardiolipin, and beta-2 glycoprotein 12 weeks apart. The clinical criteria for the obstetric morbidity APS would be 2 consecutive unexplained miscarriages of a well-formed embryo, 3 or more of the non-consecutive miscarriages of a well-formed embryo, preeclampsia, eclampsia, growth restriction at 34 weeks, placental abruption, late preterm, or unexplained recurrent implantation failure in IVF. The laboratory criteria is the same as the above, and the non-criteria obstetric APS would be the same as the clinical criteria is the same as that of the obstetric APLA. But the laboratory criteria here would be a positive LA or a cardiolipin or beta-2 detected only once, and low positive IgG, IgM of cardiolipin or beta-2 glycoprotein titers, and persistent positive of non-criteria antiphospholipid, which includes cardiolipin and beta-2 glycoprotein, along with the resistance to anaxin 5 and thrombocytopenia. The pathogenesis is the same. They say there is some genetical predisposition, but predominantly the increase has also been associated with smoking. It is because of the 2-hit theory, which leads to a prothrombic state. So the development of the phospholipid syndrome leads to, it's mainly because of the platelet activation, the production of the intercellular reactive oxygen species, the induction of the complement cascade, which increases the inflammation in the placental bed, also the expression of the tissue factor in the endothelium and the innate immune cells, the activation of the nuclear factors, as well as the release of the pro-inflammatory cytokines. Here we do see the placental infarctions were very much evident, and most of the histopathology that we have studied from a patient who has APLA positive with abruption or even IUGR did conclude the same. The risk estimation becomes very important prior to pregnancy, so we are well aware and prepared for what's going to come up next, especially the high-risk categories where there is a high titers or when there is triple antibody positive status. So this is another set of population which is much more difficult to treat when it is secondary, which is in association with SLE. So it affects to close to 15 to 25% of all pregnancies. Live birth is in these kind of, especially when I want to particularly bring up this case where we had a APLA positive case, and she was SLE, and in pregnancy we had 2 losses, and then we had to put her on steroids with heparin, and things were going good where she had an abruption. So here there was a lot of factors which had to be considered. Even though the inflammation was well under control, she was monitored. I wouldn't say APLA with SLE is easy to manage. I would still stick to saying that APLA without SLE is much easier to clinically manage than with SLE. A very famous study, which was the PROMISE study, which was done, showed adverse pregnancy outcome in a person with APLA and SLE in close to 19%. The clinical manifestation of women with antiphospholipid syndrome, like we've extensively discussed, recurrent miscarriages, late losses because of growth restriction. These women particularly have early onset IUGR. The Doppler changes are much easily picked up. Even in the NT-NB scan, we do see elevated uterine artery pressure, which may kind of urge us to start or initiate antiplatelets or increase the dose of the anticoagulant which has been administered. So, yes, pregnancy is a hypercoagulable state. Added on with this, when there is APLA, it is going to increase the possibility of a woman having the hypercoagulability kind of doubles up to give us even more bigger complications like DVT. So patient with thrombotic manifestation and phospholipids should be treated with warfarin for many years, and possibly they may require a lifelong treatment as well. But obstetric APLA do not call for continuous treatment. The PT-INR has to be maintained between 2 to 3 in these women. But what is very important for us as OBGYNs is where we will have to change over. If she is on warfarin, has to be changed over to low molecular weight heparin once a pregnancy is confirmed, as it has complications or impact on the baby causing fetal malformations, which is very well known, which is known as the fetal warfarin embryopathy, which causes typical abnormalities in the fetus which is developing. So the management of an antiphospholipid positive women, if she's going to come to us prior to pregnancy, which is always considered better, would be to initiate her on immunomodulators. Find out if she's a primary or a secondary one. I would want to evaluate to see if she has any other associated antibodies, and initiate her on base immunomodulators and give her a good brief period, following which we will ask her to start the process of conception. So in the course of pregnancy, yes, a low dose aspirin along with an anticoagulant will be initiated. Based on the weight, we do give them a therapeutic dose if she is a proven APLA case. So a low dose aspirin along with low molecular weight heparin is administered. And a proven case will continue her low dose, heparin 6 weeks post delivery as well. Refractory cases of APLA has been treated with hydroxychloroquine, low dose of prednisolone and IVIG. This is one of the reasons why I don't want to say APLA is much easier to treat than SLE. What's upcoming is a lot of European countries are using statins and eculizumab in the current treatment of obstetric APLA cases. Eculizumab is a long-acting humanized monoclonal antibody which mainly targets complement 5. And extensive studies has been performed mainly in the European countries, which do claim that there is reduction of preeclampsia, HELP, IUGR in the population of obstetric APLA. Pravastatins are also again considered, and this trial was conducted in Barcelona, where they did say the rate of women, especially who are not the high-risk categories, single antibody positive women, did have a fruitful outcome. They even said the rate of growth restriction were not significantly elevated in the APLA population. What is upcoming is there are other drugs which are also which are extensively being studied to be incorporated, and maybe in the next few years we may have more medications which can be started for the treatment of obstetric abscess. Thyroid antibodies, on the other hand, this is one set of antibodies none of my esteemed organization is still accepting. So thyroid antibodies is associated with adverse pregnancy outcome in the form of preterm pregnancy or pregnancy losses and even long-standing infertility. The association between thyroid antibodies and its impact on miscarriages, this is an excellent study which did show a significant association of elevated anti-TPO with that of the early pregnancy losses. This is a meta-analysis which had an p-value of a very significant number, which also suggested that elevated anti-TPO did have an impact, and the losses were predominantly in the first trimester. The 2017 guidelines of the American Thyroid Association did say that the thyroid autoantibodies is associated with adverse pregnancy outcomes. Here they claim that preterm labor was the higher cause, and they did attribute it to PPROM or leak or IUGR, more than that of first trimester losses. The thyroid peroxidase antibodies, this was a prospective study which was done, which showed that a large, the total number of population was for the unexplained RPL was considered here, and the positive thyroid antibodies did have a reduced birth rate in that particular population. So higher antibody titers did show that it was, the birth rate of that population was much lesser. This prospective study showed that a woman who has, we start treating, as OBGYNs again, we start treating a woman with a TSH of close to 3.5, also with levothyroxine, as well as, if required, we do evaluate them for thyroid antibodies. We want her TSH to be maintained less than 2.5. So they said, if you are treating her with levothyroxine, and after treating her with levothyroxine also you are not able to stabilize her TSH, perform T3, T4, and if required, we go ahead to perform the anti-TPO and anti-TG. Back to where we started, anti-nuclear antibodies. My esteemed organizations are still very controversial about including them in the standard investigations protocol for recurrent pregnancy losses, but its association is having an impact, and the titration, what we would initiate the treatment for them would be 1:160. So here, whenever a woman is diagnosed with ANA positive status, why is it, or what is the pathogenesis for recurrent pregnancy loss in her, would be because it has an impact on the oocyte quality, the embryo which develops because of the persistent exposure to the inflammatory cytokines, and also the activation of an intraplacental complement cascade is seen, which causes higher inflammation in the placental bed, and the activation of the dendritic cells, resulting in an increased production of cytokines again, and deposition of the immune complexes in the placental bed. So anti-nuclear antibody positive status, excellent number of studies have now been incorporated, and in the year 2025, in the ChanRe guidelines, they do say you can perform ANA now. We only used to accept APLA, but now we do say you can perform ANA in a selected population, more so in someone who's having symptoms, or when the titers, when we perform ANA, is more than 1:160. Yes. So this is the study, and we have quoted n number of studies in ChanRe this time, and there is significantly good response, and we are looking at perhaps even acceptance of ANA to be one of the investigation module for recurrent pregnancy loss. The other organ-specific, rather rare autoantibodies would be the anti-endometrial antibodies, which is predominantly found in recurrent implantation failures as well as recurrent pregnancy losses, more so in a woman who has a pre-existing disease like an endometriosis, adenomyosis, or chronic endometritis in the endometrial bed. Anti-ovarian antibodies, these set of population usually present with either low ovarian reserve or an embryo which is not of a good grade. If she goes to an IVF and we perform an IVF cycle, the embryo which is formed is not of a good grade. Also, this set of population have a genetical abnormality when PGTA has been performed on these embryos. Anti-sperm antibodies no longer included, and anti-fibrin IgM antibodies mainly, these antibodies may be secondary phenomenon to the altered fibrin 1 metabolism. So, like I keep saying, my esteemed organization, the DGGG accepts APLA to be the screening module, and we do perform that as one of the first few investigations in a recurrent pregnancy loss, mainly in the first trimester. ChanRe accepts it, ASRM and RCOG, all three of them, yes, all four of them, yes, 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 and yes. But when it comes to AMA and thyroid antibodies, the DGGG does say that if there is significant association, yes, you can perform the same. But ChanRe says you can consider it, but ASR and RCOG agreed top guidelines doesn't accept anti-thyroid antibodies or ANA even till date. Thyroid antibodies in the same phase, they are again not very well accepted by ASRM as well as RCOG. Whenever the TSH level is more than 2.5, what we do perform is the T3, T4, and then we go ahead to perform the thyroid antibodies. And in this subset of population, again, if a woman does come with an ANA positive status and her titers are quite big and she has significant symptoms, like we have extensively discussed from morning, but in my department, mainly one particular thing what we will want to give a little more importance to is her history. If she's going to give me a history of a previous pregnancy where the baby had cardiac problem or a conductive cardiac defect in the heart, maybe it is an ANA positive with a Rho antibody positive at that state, which would have caused this kind of problem. So this requires a little bit more of a detailed investigations and history, which would help me. So the previous pregnancy scan would show a conductive cardiac blockage. The baby went into a 3rd degree cardiac blockage and had an hydrops and intrauterine demise. These are some of the follow-ups that will be very important for us. So the recommended test now would be APLA panel for RPL, which is accepted by most of the organizations, ANA and if positive and symptomatically or clinical history based, the extended panel, and thyroid antibodies or based on her TSH, T3, T4 is proceeded towards. So the clinical relevance here would be to predict the rate of miscarriages. They guide us in initiation of immunomodulators and also when it is required anticoagulant therapy. This helps us monitor the placental function. I would do more number of scans for a patient who comes with APLA. I have patients whom we do weekly weekly screening of Doppler to see the flow pattern if altered, which does alter. Even if a week back it is good, they can decline. She can come with an abruption even 2 weeks later. So continuous and very close monitoring with scans and Doppler. So to conclude, most obstetric APLA still remains to be one of the most commonly performed autoantibody testing in recurrent pregnancy loss. There is a good acceptance for ANA and thyroid antibodies also by a lot of societies. And we are looking at anti-ovarian antibodies for a low ovarian reserve. A 21-year-old with AMH of 0.2, 0.3 is definitely not accepted. So yes, we can consider the additional ones. So an abnormal autoimmune function leads to reproductive failures at different stages of her phase. It can be, whenever there is an early loss, like I said, whenever there's an early loss, I would definitely want to consider APLA. If it is coming towards the 2nd trimester and she does give a significant alteration in the cardiac function of the fetus, then looking into ANA and the extended panel. So a clinical asymptomatic patient with abnormal autoimmune functions having reproductive failure is called a reproductive autoimmune failure syndrome, which is extensively being studied in our department today. And autoantibodies workup is way too essential for this subset of population. This helps us to identify the causative agent and formulate a treatment just for her. So any of these recurrent pregnancy loss patients, when they are addressed to us, we do have a set of investigations we perform. We cater to what is positive in her. So we have a treatment module which is exactly done for her, and that is how we proceed. Thank you so much.